I mean, first of all, recognize that they're cats, not dogs. I think that's number one. Number two is, recognize that a lot of these cats need space, need places to hide.
Welcome to the Purr Podcast, your favorite feline-focused podcast, where we dive into all things feline, medicine, surgery, behavior, and of course, a sprinkle of veterinary gossip along the way.
I'm Dr. Jolle Krippenstein, feline fanatic, surgery nerd, and self-proclaimed lover of all things awkwardly cat-related.
And I'm Dr. Susan Little, proud cat vet, podcast enthusiast, and your guide to the wonderfully weird world of feline medicine. Let's get started. Hi, I'm Dr. Susan Little.
And Dr. Jolle Krippenstein. It's the Purr Podcast.
I think that's 2 days in a row. We actually did one out of many.
We nailed it.
Yeah. The first one that we recorded yesterday, I remembered the name of the podcast, but forgot me.
Her own name. She forgot her own
I think everyone knows who you are, so that's
no. I just forgot to. Anyway.
Yeah, I was a little worried about that. Maybe old age is setting in.
Yeah.
After all.
Yeah. You're not that far behind me, buddy.
Wow.
Yeah. You're not that far.
I think I'm just going to leave now.
No, we're always compared to the two Muppets and the.
Yeah, totally.
Oh yeah, if you're a certain age, the two Muppets up in the gallery.
Yeah, totally. Yeah,
that's us.
Yeah, I believe it.
One of our podcast guests yesterday, Renee Rusinski, asked us if we needed a therapist.
This is, I think, podcast number 240.
Oh my gosh.
239. So
Year 8.
Year 8. So what year were you in? Because you are a repeat offender.
And he's an early one.
This is my
early-ish.
third one, I think.
Ooh,
yeah, I think you're on number 3.
Yeah.
Lappin has a big lead on.
Well, it's hard to beat Dr. Lappin.
Because he's everywhere.
It's Dr. Lyons, Dr. Lappin, and Steve.
And Steve Dale.
They're fighting for the number 1
Is that
spot.
the leaderboard?
Yeah, that's the leaderboard.
I can't compete with those people.
Oh, you're pretty high.
Yeah.
As a matter of fact, if you did 3 times,
it's
really good.
I feel honored. Well, thank you for having me.
Right.
Yeah,
well, we should
introduce you.
Yeah, we.
Let's not forget me this time.
Yeah. We did.
Beyond the wall, talking to someone from beyond the wall, up north.
Yeah,
that's right.
We have Dr. Serge Chalhoub.
That's right.
How did you end up getting a French first name?
I was born and raised in Montreal. So my parents are immigrants from Egypt, moved to Lebanon, Civil War, moved to Montreal, and I was born there. And
so they picked a francophone first name.
Exactly. Yeah, and they speak French fluently.
Okay.
So it was kind of perfect.
Okay. Yes, I think in Lebanon, French has been still pretty common.
Correct.
Commonly taught, right?
Exactly.
Yeah.
And when my parents were born in Egypt, at that time, that generation, the 40s, 50s, there was a strong French influence.
Yeah. Through that whole area.
Yeah, I love Egypt.
Yeah, it's beautiful. It is.
Yeah. Oh, okay. Yeah. Okay. So I've meant to ask you that many times, and so now it suddenly popped into my head. Yeah.
And were you born in Canada or were you born
in Montreal? Yeah, my brother was born in Beirut, and I was born in Montreal.
Yeah.
Oh wow, that's cool.
Yeah.
Does he have
very
nice French name?
Alfred, actually. Yeah, so he does. Yeah. And my parents are Raymond and Suzanne.
Oh my
gosh.
Yeah.
Really?
Yeah.
Oh my gosh.
Yeah, very French influence.
My husband's family comes from like Syria and then and movements like Lebanon, then you have to leave Syria because the things are bad. You go to Lebanon, go to Egypt.
Yeah.
And then to the U.S., although some went to Panama on the way.
Yeah.
Right. And so they all have not all, but most of them have very like North American sounding first names. Yeah. The only problem is they reuse the same names generation after generation.
Yeah.
Right. My husband's family. So I'm like, oh my gosh.
It's so true. There's a lot of Josephs in my family because it's that repeated.
Yeah. Generational thing.
Yeah.
Are there any other Yolas?
No Yola
there's
in my family.
No. Do you have a middle name, Yola?
No.
Is it the Dutch people?
It's not as common. I mean, if you're Catholic, you do.
Right.
If you're Protestant, you don't.
So it's not common to have a middle name.
Yeah.
And I have nothing, so
So there you go.
And the name, as a matter of fact, was chosen by my grandmother because she was a Frisian, which is a very little province in the northern part of Holland where they speak a completely different language. And so because she was Frisian, I'm quarter Frisian.
Right.
I got a Frisian name.
So Yola is Frisian. Okay. I remember you saying that it's not common in the Netherlands, but that might explain why it's a Frisian name. Yeah, okay.
Very cool.
Yeah,
Yes, it is cool. It's cool. Serge, you were at the University of Montreal, weren't you?
I was a student and an intern there.
Right.
Yep.
That's what I remember.
Yep.
Somewhere in your CV that I didn't look at.
Good memory.
Right.
Good
Yes,
memory.
remember.
And your residency?
At AMC.
AMC.
Oh,
yes.
that's right.
I remember.
Yeah, and nephrology fellowship there as well. And stayed as staff doctor and then been at Calgary since 2012.
Yeah. So Calgary is the newest vet school in Canada.
Correct.
Do you know when it opened?
Officially in 2008 with the first graduating class in 2012, which is when I started.
Right. Okay. Yeah. So you've been there since, and it's changed a lot.
Oh my goodness. Yeah. We started with 30 students and now we went to 50 and quickly went to 100.
Yeah. That's a lot of growth in a short period of time.
It is.
Yeah. But you mentioned one thing that I really like. You mentioned that the community clinic it specifically serves like underserved populations, right?
That's
people
right.
who have trouble accessing pet care.
Yep, and that's a big thing at the University of Calgary. So I coordinate the CUPS Clinic, which is the Calgary Urban Project Society. It's a group in Calgary, helps underserved or disadvantaged Calgarians get back on their feet. And we've had for now 10 years, a third-year clinic where we help them. That's something I coordinate. And then we now have our own community clinic at the university, which just opened its doors a few months ago with the same mandate, serving disadvantaged Calgarians and their pets. And so far, it's been absolutely phenomenal.
Yeah. I bet. I bet. Do you know the community vet outreach people? So it's an organization that runs services for disadvantaged people and their pets. And they operate in Ottawa and a couple other places. And they do kind of the same thing. It's like underprivileged people, especially people who are, we're not supposed to say homeless, unhoused, right? Without a home that have pets, right? And they try to communicate a little bit of help for the person and then care for the pets as well. So I donate to supplies to them quite regularly.
That sounds amazing.
Yeah. It's neat to hear about all these initiatives, right?
Yeah.
So do we know how many cats are part of those families, or is it really the?
That's a good question. I don't know official numbers for CUPS Clinic, just because we've been doing it for 10 years. I'd say easily half to almost 2/3 are cats coming in. Yeah. And often multi-cat households versus when the dogs come in, it's usually one dog. Cats, it's usually 2, 3. And that might have been because of, lack of access to,
spay-neuter services, like just primary services.
Totally, which is a big thing we offer as well. So I think that's a big reason why we see them. And they're almost like, please help. We love these cats, but we need, a little more.
We need to do something.
Yeah, exactly.
Otherwise we'll be even more cats.
Yeah, exactly.
Yeah. And it would include vaccinations. Where you vaccinate for rabies, I think.
Yes, that's correct. Yep. So a lot of preventative medicine, lots of nutrition. So it's a big thing we do because again, most don't have access to quality nutrition or even the knowledge behind quality nutrition. And so that is a big thing that we do is we discuss a lot about nutrition and preventative care.
And it's good nutrition is probably expensive too, right?
It is expensive. And at the end of the day, one thing we like to teach our students is how to read a label to also help our clients be able to at least point out or pick out a couple of things that are maybe better for their animal versus just going from the marketing, at the pet store, things that they can afford, at least to make a more informed decision.
Yeah.
I'm a bit surprised that there's that many cats that come into this clinic, but also now delighted because they're getting care.
Yeah. It's also good for the students.
It's amazing. The thing I love is our students in general, when we go through veterinary school, they have a lot of access to dogs, physical exam labs, auscultation labs, etc. Right. Very few cats. So this is a great opportunity for them to not only interact with cats, but do a physical exam on a cat, because we all know cats are aliens from outer space. They're different. You can't treat them like a dog. And so it's been a great experience, even just for that.
Yeah.
Mhm.
I love that because you're right. Look how many, and I think it's true in the US too, right, Yola, that students graduate with less hands-on with cats.
Oh, absolutely.
Right?
Yeah.
Although if you have a community practice, then it probably is a little better. But
Probably a little better.
Right.
No,
Yeah.
I don't remember how many cats. Of course, I was tertiary care, but
still.
the cats was like 10-20%
Right.
of all the
Yeah.
cases that we
Yeah.
saw.
Yeah.
So,
Yeah.
But
Yeah.
and-
That's a nice way of balancing out this like sort of canine heavy
right.
component
For sure.
of most vet
Yeah.
schools. Yeah.
So what kind of diseases do you see in cats in your community?
Yeah, the community service ones.
I mean, so far, we've been open a few months, but we do see obesity is a big thing.
Oh, really?
Big thing, which is great for the students because I think they never call it a disease or a condition. Just say, oh, the cats are worried. Well, no. The cat is overweight. Let's talk about that. Let's make a problem list and differentials based on that. And how do we address it? That would be a big thing. Diabetes mellitus is a big thing, probably again associated to the obesity. And chronic kidney disease for sure, pops up, especially for those cats that are 9 years and above.
Interesting
Yeah.
that when we talk to you, it always ends up with that.
I don't know what
kidneys.
you're talking about.
I-
Oh, I love your kidney pin.
Thanks. Yeah, Kathy
Oh.
Langston gave that to me.
Did
Oh,
she?
Yeah, when I finished my fellowship. Yeah,
That's gorgeous. A
Yeah.
nice little enamel kidney pin.
yeah,
Right.
totally. Yeah.
So,
Oh.
Serge, you might want to explain to our audience that,
Why
you
the
were
kidney?
on before the pandemic, so they might not remember what your specialty is. Or your
That's
specialty
right, yeah.
is.
So I'm an internal medicine specialist, but there's no doubt. I mean, the kidneys are my
Your
kidneys and
jams?
bladder. Yeah. We recently just published iCatCare guidelines on feline urinary tract disease. So
Yeah.
So,
And you're
yeah.
already answering my last question of the
Yeah.
podcast, which is, can you talk about a publication that you recently did? So,
yeah,
okay.
absolutely. I mean, I'm
Divulge there.
big fan of that. I mean, just an awesome group of worldwide people who love cats, and we got together and looked at best practices, evidence-based literature to put together a guidance document. The one before that, surprisingly enough, is my favorite, and that's the iCatCare. Well, formerly it was ISFM guidelines for the inappetent hospitalized cat.
I know, I like that.
Because that was such an served group of cats. I would say.
Right.
Yeah, and it made it rightfully acknowledged as not a disease, but a significant problem.
Yes.
And it helped lay out, for your average GP.
Yes.
What do you do?
Exactly.
So what
Tricks
do
and
you
tips.
do?
I mean, first of all, recognize that they're cats,
Yeah.
not dogs. I think that's number one. Number two is, recognize that a lot of these cats need space, need places to hide, need calm, quiet. They don't need the barking treatment room, ICU, and also recognize how to manipulate them, how to do physical exams. Just recognize their different. Nutrition is a big thing again, nutrition early, how to do nutrition, not to be scared about feeding tubes for that inappetent hospitalized cat, et cetera, enrichment strategies. I love this consensus guideline. Lots of goodies.
And I always think that the sooner we can get the cats out of the hospital and get them home.
Yes, agreed.
We should post a link on our website.
We will.
Yeah.
We will.
Mm-hmm.
Good reminder.
Oh, yeah.
Good reminder.
Very cool. Thank you.
To both of the guidelines.
Yeah.
I still hear vets from time to time who have a hospitalized sick cat and they don't want to send it home because it's not eating.
Right.
Yeah.
Mhm.
And
Yep.
right. And if everything else, aside from appetite, says it's okay to send it home.
Mhm.
Send
Right. Give it a try.
Yeah.
Yeah. I mean, the worst, they come back the next day.
Yeah, exactly.
Yeah.
Exactly. Yeah,
Yeah.
give it a try.
Exactly.
The urinary, the lower urinary, that's the first time, is it not, for lower urinary as its own guidelines?
So where this came about, we were at the ISFM conference in Dublin, I think in 2023, and we were chatting with the ISFM people, and because it was a very kidney focused conference, and we were like, wait a minute, I couldn't find a single consensus guideline on lower urinary tract disease in cats, and so I made the mistake of suggesting it. Because then it quickly turned around as great. You're going to be one of the co-authors, Sam Taylor, who very much appreciate. I was like, "Do you want to lead it? Do you want to lead it?" I'm like, "Please no, please no." So of course she did, which was great. But yeah, it was just a wonderful team of people working on it.
But there are ACVM guidelines on stones, aren't there?
Stones, yes, yes,
Stone specific.
exactly.
Right.
Yeah, there seems to be an unwritten rule that if you have the idea for the guidelines, you're in.
Yeah, yeah, totally.
Yes.
Yeah.
Especially when
Very
you
much
bring it
so.
up.
Yeah, very much. Yeah.
Any other good ideas that we can push towards things?
Well, we do need a newer, refreshed guidelines on chronic kidney disease.
Okay, congratulations.
Thank you. Yeah. I think Sam knows that.
Yeah, but it does highlight, right, that these things are not static. Hopefully they're not static.
Right.
Hopefully we learn enough.
Totally.
So for our audience, can you tell us how difficult it is to write guidelines?
It is a challenge, mainly for one, grade 1 evidence in veterinary medicine is not common,
Right.
So you're dealing with a lot of grade 2, mostly grade 3, to be honest, and sometimes grade 4, right? And I think it's often when we get to that grade 3, grade 4, how do we tell people, hey, this is best practice and feel confident in that? And I think that's one thing I've appreciated is, across the Atlantic, we do some things different. And that came to light in the lower urinary tract guidelines. And it was very interesting. So I think it was some sections were a healthy scientific compromise, I like to call it.
Yeah, because
that's always the issue.
Once you're down in like the grade 3 and grade 4, which are the lowest levels of almost no scientific evidence,
right?
It becomes then an individual person's experience, the population they see.
Exactly.
Which can rightfully be somewhat different from the population you see, right?
Yeah, very much so.
Yeah, and so there are, I don't know all the ACVIM guidelines do it now, but some of them now will indicate when a recommendation is a consensus, and then where person X or person Y has a different
opinion.
Yeah, like the literally. In the interest of clarity.
I do think though that lower urinary tract disease, just like renal disease, is probably one of the best studied diseases in the Ds and cats, and so there is some grade 1 evidence for both, which is already really good, because if you look at other diseases or other issues, often it's not.
Yes,
so I think that for I remember also when the ACVM stone thing came out that they had a lot of discussions about some things, but the big issues were at least clear.
This is true.
Yeah.
Very true.
And I think for specific things like that, for stones, it is.
Oh, for FIC, I think it's the same thing.
I'm not so. Well, what do you think, Serge, in terms of like how much sort of grade 1, grade 2 evidence?
I feel the stones is more clear personally, and maybe it's just because I worked on the lower urinary tract, and maybe I know too much of what we put in or didn't put in. But you get to something like prazosin, the hot topic the last couple of years, and do it, don't do it, we should do it, maybe don't do it, absolutely not, and so it was just very interesting. I feel with stones, it's a little less, there's maybe more less fuzzy. Yeah. There's a fair bit of fuzzy, but you're correct. Some of the grade 1, grade 2 evidence for lower urinary tract disease is pretty clear.
I probably referred to the nutrition role. Although there was something coming out, I don't know, like 2 years ago, that didn't mention nutrition at all.
Really?
I think it came from iCatCare. There was some, I don't remember, it was an article, maybe it was in the journal Small Practice, and I'm so surprised that, because you still have that camp that goes completely environmental versus the use of nutrition. So there's very strong opinions in the urinary and renal field. I always feel, although renal it probably is a little bit more clear
nowadays. I would say yes.
Yeah, things come a bit more into focus. I think with non-stone lower urinary tract disease, there's still like a really wide range of things that people think of, and that especially when you get out into general practice or even in referral practice, there's still quite a wide range. You mentioned the drug dilemma. Prazosin, use it or not. And there's a bunch of other like products and drugs.
It's
mainly lots of products.
That's probably true.
And a lot of them just. Even prazosin only has a couple of studies, right? And so we still have some unresolved things. I'm a bit of a minimalist. If I can take away a drug and see if we do at least as well without it, because it's a cat, I'm going to take it away.
Agreed. The role of stress in these cases is, of course, course.
There's no doubt. I mean, we keep it pretty simple. We focus on nutrition in the acute phase, nutrition in the preventative phase, and pain control. Exactly. Right. That's the biggest things. And, we've always prioritized that. So for us, stopping or, holding on prazosin right now wasn't a big change. And there's no doubt. I mean, for one thing, we get to keep our fingers, because that's the thing. I mean, you send an owner home with some pills and they don't know how to pill their cat, or, their cat is stressed in the hospital. And it's like, see, you can pill your cat, and then you go home and try to do it. Forget it. It's a very different ball.
It's a rodeo.
And they may go home on a couple of different oral drugs or supplements or products, right? And so I think one of the things that's important is when an owner has multiple things to give, is to prioritize. If you can only get one in today, what's the one?
That's what we do.
What supplement do you use?
I don't, but there are a lot.
Yeah. But I mean, those are the ones that have no evidence.
Well, true, but they are widely used.
Right.
Yeah.
But that's in general with supplements,
No, that's true. But we also have to look at the situation on the ground and the way it is. You can't pretend it doesn't exist, right?
What painkiller do you use, just before we go anywhere else?
We use buprenorphine a fair bit for home. That's probably the most common one we use. Yeah, for home.
That's oral?
Correct. Yeah. Transmucosal. Right. Probably the easiest for us to use. I mean,
How do they like it?
It's such a small amount.
It's such a small amount that for owners, A, it's easy because it's a small amount. B, for cats, it's so quick. There's no doubt a lot of cats, do the thing after, my favorite,
Okay.
Not
You
for
need
very
to see
long.
Not for very long, yeah.
You do need to see the video for this. So
Be careful, that might become a meme.
I'm okay to do that, yeah. And we do use a lot of, as much as possible, transdermal drugs. So, transdermal mirtazapine is to us a godsend, because it's,
Isn't it?
Just makes it so much easier. And for owners, one less thing they have to worry about.
Where do you stand on NSAIDs for pain control in the lower urinary?
Oh,
I know, I feel the same way, which is why I'm asking.
That's a tricky one. I think, especially for that lower urinary tract cat that comes in, their percent dehydration or, lack of proper knowledge on their perfusion is a problem.
Yeah.
And that's where I think we run into problems. It's, let's give NSAIDs for the next 7 days. And I worry that cat, A, isn't drinking enough, eating enough, and all of a sudden we're giving it an NSAID. I think we can run into trouble. The reality is there's two pretty good studies, thinking about good studies, looking at the role of NSAID, specifically meloxicam, in the acute phase and in the preventive phase, and showed no statistical
advantage.
Yeah, exactly. So
yeah. And it may be, there's different kinds of pain. It originates from different parts of the nervous system.
Exactly.
And it may be that I always say cats were built for opioids. I mean, they're the poster child for opioids.
But there is no significant difference in episodes, or is no significant difference in pain?
In episodes of recurrence, I don't think they looked at pain specifically.
Because I think that's the key here. I mean, you still can have episodes while you don't have as much pain, which I think is, we need to disconnect that a little bit. So
that's a very interesting point.
That not having or not influencing the episode does not mean that the cat is not in pain.
Right.
So.
I think where we get into, and that's actually a great point. I've honestly never thought of it that way. So I think where, current thinking is that, the issue with the bladder isn't necessarily a strong inflammatory associated pain. Yes, there's inflammation, but that may not be the problem. Is that it's more similar to bladder pain syndrome in human females. Exactly neurogenic. So then the big question is, do we need that NSAID where we don't know the cat's hydration status and renal function?
Right. No, that's a very good point.
Whereas opioids are pretty safe.
Right.
But I do like that. I mean, for a cat that's well hydrated, eating, no concerns.
Yeah.
You made me think, what Yola just said made me think we recorded some episodes with Katie Tolbert. Recently, and we were talking about, it was when we were talking about IBD, I think, Yola, and we were talking about how the cat probably has or is developing IBD potentially for a long time before there's obvious enough symptoms, right? And she was talking about a study in the lesser species in canines where they're actually looking at that to see, they use a whole bunch of fancy tests.
I don't think we are allowed to call it IBD anymore. There's a new term.
Oh.
Do you know the CEA or whatever it is?
The chronic enteropathy.
Right. I mean,
that's been around.
The latest thing just came out that there's this consensus now that we have to use CEA, CB, CD. I mean, it's this whole. IBD is much easier, but there's this whole discussion about all these different forms of whatever the new term is, and I'm like, oh my gosh.
I mean, honestly, once I just turned 50. For one, I'm going to stick with IBD. Thank you. And two, that's why I like the kidneys better. Mm-hmm. So
right,
Sometimes
CKD.
CKD is
we've been stuck on that. We're good
for a while.
Right?
Because it used to be CRF.
Yes. I think for something like IBD, just giving it a new name really does not help.
I think part of the issue, if we're going to switch gears just a little bit, is dietary intolerance, IBD. That's been a struggle for a lot of people for years now to differentiate the two versus calling everything IBD, which is what, when I went to school, what we used to do, right? Everything you're IBD.
Yeah. Right.
So I mean, now a new naming system. Of course, I'm not that familiar with it, so I'd have to investigate, but I can see how it would be confusing.
It's interesting that the surgeon needs to come up.
Well,
we have the feline specialist.
You're getting the biopsies.
You clearly read more than I do.
Yes.
But just like circling back a bit, it does make you wonder, right? These cats that have intermittent episodes of bladder pain, right?
That was a very good.
I know. I thought it was a very nice connection. That's probably it for the year. But it does make you wonder, because cats being cats are so good at hiding things, right? Is there almost a prodromal period, right? When they're if they could talk, they're saying, "Oh, we're great today."
Right. Exactly. I ate half my meal today. You should pay attention to that because something's not right.
That's the
challenge.
challenge.
An NSAID.
Just need an NSAID.
Right.
I
think we're almost at the end of number one, so I just don't want.
I just want to put in a last plug though, but that's where nutrition does come in, right? That we may be able to all other things being equal, and the cat doesn't have any other dietary issues. We do have some therapeutic foods that can make the life of these cats better, which I think is a big deal.
I'm happy you say that, because I think that veterinarians in general do not think nutrition first. They always think nutrition at the end. So they did all the other stuff, and the diagnostics and whatever. And I think we need to insert nutrition much earlier into the. We do like drugs, but I think for a lot of the things that we regularly see, nutrition has a very specific role, and we need to put them much earlier into our treatment protocol. Because I think owners get really tired of all the stuff that we do to them and their cats. And then when you come with, and you have to buy this bag of nutrition for the rest of your life, they're like, it's too much.
And it's interesting, again, those guidelines on the inappetent hospitalized cat, if you look at it, often nutrition is one of the first things, because we really wanted to highlight the importance of nutrition, especially in our cats.
So do you do nutrition in the hospital, or do you wait and do it at home?
Both. So it depends. The sick, inappetent, potentially, if we're looking at, idiopathic cystitis cat or lower urinary tract cat in the hospital, depending on where they're at, often we just want them to eat. That's probably goal number one. Make them feel better, treat the pain, but the key thing is we want to make sure they eat. For home, there's no doubt we're already talking to the owners about that.
That's great. Oh, well, we're going to have to stop here, Yola.
Yes, I guess that's another cliffhanger there. We'll come back to this, because I'm interested in this topic for sure.
All right.
This is the Purr Podcast, where we talk cats, laugh a lot, and learn something new every episode. Together, we bring you the latest updates, surprising cases, expert interviews, and just a touch of chaos, because nothing with cats ever goes as planned.
So whether you're a seasoned veterinary pro, a new grad, or you're just here for the cat puns, you've come to the right place.